This morning, it's my pleasure to welcome Dr. Aparna Goel back to UCSF and introduce her as our second GI Grand Round Speaker of the day. Dr. Goel is an associate professor of medicine at Stanford University. She obtained her medical degree from Jefferson Medical College and subsequently completed her internal medicine residency at UCSF. She was one of the first quality improvement and patient safety chief fellows at the San Francisco VA. She then completed her GI and transplant hepatology fellowships at Mount Sinai in New York, and then found her way back to the Better Coast for training. She's a transplant hepatologist at Stanford with a specific clinical and research interest in autoimmune liver diseases, including autoimmune hepatitis, PSC, and PBC. She serves as the PI on several clinical trials related to these diseases, and she's the program director for the Transplant Hepatology Fellowship at Stanford, and also the associate program director for the GI Fellowship at Stanford. So thank you so much, Dr. Goel. Looking forward to your talk.
Yeah, no problem. Thank you, Edgar. And good morning, everyone. Thanks for having me. I think if I can read the audience properly, and you guys can correct me if I'm wrong, I think that there's a fair amount of GI in this audience and less hepatology. So this talk is targeted to more novel therapies and some of the newer updated stuff that's happening in PBC and cholestatic pruritus. But if we need to take a step back and like, hey, start from the beginning, then please let me know and feel free to interrupt me as we go. So my goal today was really to try to focus on PBC because that really has been the biggest hype in the last year with two newly approved therapies with more evolving treatment patterns, and trying to really figure out how we plan to integrate some of these new therapies into practice, and then secondly focus on cholestatic pruritus. So I will start from the basic in terms of pathogenesis of PBC. So as you all know, PBC is a chronic cholestatic autoimmune liver disease that targets the very smallest of the intrahepatic bile ducts. And the key features of this disease are really a lymphocytic cholangitis. So you see this T and B cell infiltration of the bile ducts. And the pathogenesis is very interesting, but central to it is a genetic susceptibility. And there's been a number of very well done family studies that have shown that first degree relatives of patients with PBC are at the greatest risk of developing disease. And I think one of the best ones done was a study that looks at monozygotic and dizygotic twins. And it showed that monozygotic twins have the highest concordance rates compared to all twins. And it had a concordance rate of 63% for development of PBC. And the flip side of that is that 37% of the monozygotic twins did not have PBC, and that really highlights the environmental triggers that likely also contribute to the pathogenesis of the disease process. So there's more to the story besides just genetics. And you see that with the lymphocytic cholangitis and the destruction of the bile ducts, there's loss of this bicarbonate umbrella that really helps protect the biliary cholangiocytes up here. There's gradual loss of bile ducts, and then eventually with cholestasis, you end up developing fibrosis and a biliary cirrhosis. So it's a rare disease. The prevalence in the US is estimated, the highest prevalence rates are estimated to be about 30 per 100,000 people. And despite it being rare, it is the most common cholestatic liver disease. It's more common in females compared to males, although recent studies do indicate that the incidence of PBC in males is increasing. The age of onset is usually 40s to 60s, and rarely we diagnose it in people that are less than 25. So we really don't see this in the pediatric population at all. And although in terms of demographics, although it's most common among white individuals, Black and Hispanic people with PBC are at the greatest risk for having suboptimal responses to standard first-line therapy or suboptimal outcomes. And the landmark feature, the landmark autoantibody for this disease is the anti-mitochondrial antibodies, the AMA. And this is present in over 90% of people that have PBC. And remember, this targets the E2 subunit of the pyruvate dehydrogenase complex. And now, this used to be the only commercially available antibody that we had. There are now two other commercially available PBC-specific ANAs that you can test for, and those are the GP210 or the SP100. So these occur in up to 50% of patients that are AMA negative. So you might see, sort of chart lore in a lot of the patients that we follow with autoimmune cholangiopathy, AMA negative PBC, nonspecific cholestatic disease, and you're not entirely sure if the diagnosis is PBC or not. Those patients should probably have ANAs checked and have these PBC specific ANAs evaluated if their ANA is positive. Obviously, if your ANA is negative, you're not going to have a PBC specific ANA. So it is the overall PBC population, those two antibodies are present in up to 25% of patients, but specifically in those patients that are AMA negative, we see it in about a half of those patients. And in other coexistent autoimmune conditions that we tend to see with PBC are Sicca syndrome, so dry eyes, dry mouth, thyroid disease, arthritis, Sjogren's syndrome, or scleroderma. There's other coexistent conditions that include xanthelasmas, and this is the picture that's shown here, hyperlipidemia, low bone density, which is important to monitor for, and then some right upper quadrant discomfort or hepatomegaly. And while a biopsy is diagnostic, it's not usually needed for most of these patients. And if you do MRCP, ERCP, it's usually normal for these patients because remember, it's the really, really small intrahepatic ducts that are affected, unlike in PSC, which is more the larger ducts. The diagnostic criteria for PBC includes having two of the three following present. So you have to have a persistent elevation of cholestatic markers that includes serum alk-Phos or GGT for at least 6 months, the presence of a serum AMA at a high titer or PBC-specific ANAs if your AMA is negative, or you can have liver histology that's consistent with PBC, which is really this non-suppurative cholangitis. So these floor granulomas, these bile duct lesions, those floor bile duct lesions that we tend to see. Although in the biopsies, we can miss those. So it's not the most sensitive test as well. And I think that this schematic really nicely depicts the natural history of PBC if it's untreated. And I think a nice way to think about PBC or the destruction of bile ducts from any cholestatic process is that we're born with a finite number of bile ducts, and our goal is to keep them for as long as possible because bile ducts do not regenerate. Unlike hepatocytes, and you can have regeneration, we don't have regeneration of our cholangiocytes. So once they're damaged and lost, they're gone. We're unable to create more of them. So as you have an autoimmune destruction of the bile ducts, that's kind of shown in this the line up here. As you have a destruction of your bile ducts, you start to begin to develop this progressive cholestasis. And eventually you hit this sort of critical point where the degree of cholestasis ends up causing a fair amount of bile acid spillover and destruction of the hepatocytes and eventually leading to a biliary cirrhosis. This is a very slowly progressive process. When in reality, patients progress at variable rates. We can see this preclinical stage where all you have is a positive antibody. And perhaps that was checked because the patient had rheumatologic disease or other complaints, and they were seen by a primary care physician or the rheumatologist, immunologist, and they had this panel of antibodies checked, and you end up discovering that the AMA is positive, but the liver tests are actually normal and the patient is asymptomatic. That stage can last a very, very long time. If you follow those patients in this preclinical stage long enough, 15% of them will move on to having early clinical signs of PBC within 5 years. So we do see that patients will likely develop the disease if they have an AMA that's positive. And then you start to see these early clinical symptoms of fatigue, pruritus, dry mouth, and dry eyes that we discussed associated with abnormal liver tests. And eventually this can progress to portal hypertension, biliary cirrhosis, and decompensation, resulting in death potentially without a liver transplantation. So when left untreated, we think that PBC progresses at one histologic stage every 1.5 to 2 years, with about half of patients developing cirrhosis at 4 years and 20% remaining stable over time if left untreated. So early diagnosis and prompt treatment is really our goal up here. And this is really nicely demonstrated from many older studies back in the UDCA era. Remember, UDCA has been approved for the treatment of PBC, since the 90s. It's been around for a long time. So just looking at historic data, this was a nice meta-analysis that was done of nearly 5,000 patients from 15 North American and European centers. And it followed patients that were treated and untreated, so untreated without UDCA and those that were treated with UDCA. And you can start to see that the transplant-free survival rate really, really markedly is different between the untreated population. So at 15 years, there's a 30% survival rate in untreated patients compared to closer to 66% in those that are treated. So the key is long-term treatment here to have the maximal positive effect. And now we have more than UDCA. So really understanding and having more dynamic management of these patients, and individualizing the treatment for these patients in terms of their treatment and their responses is key in this sort of era of PBC. So our job is not just done by starting UDCA anymore, and the goals have really shifted here. So I'm going to switch to a case, and I don't know if anyone on the line can maybe help me see if anyone wants to answer a question, if there are hepatologists or people, fellows maybe on the line. So this is a case that is someone that I inherited a few years ago. So a 60-year-old female with hypothyroidism, Sjogren's syndrome, and Raynaud's phenomenon, who was diagnosed with PBC back in 2001. And she was diagnosed based on elevated alkaline phosphatase levels for several years, a positive antimitochondrial antibody. And she actually had a liver biopsy back in 2001 that was consistent with PBC, although technically she didn't really need it because she had two of the three criteria already. So after she was diagnosed, she was started on weight-based ursodiol and about 14 milligrams per kilogram per day, which is the adequate dose. Normally, treatment ranges between 13 to 15 mg per kg per day. And her alkaline phosphatase initially reduced to 130s after 2 years, and then it started to rise again, 170 to 200s, and her GGT rose from 70s to 130s. Her bilirubin remained in the normal range, 0.5 to 1, and her albumin remained normal. So I saw her for the first time. This was probably in 2017, 2016, 2017 is when I first started to manage her and take care of her. So I need thoughts on what you would do next with this patient. And Abby, you might need to help me call on someone, or you can feel free to put it in the chat.
I think we have a bunch of fellows if anyone wants to take it on.
Not yet. Okay. So we've got some learning to do, I guess. So this is someone that no longer has an adequate response to ursodiol. So we're thinking about what our next line of therapy should be, or do we have to really consider additional therapy for her? Can we let her live with an alk phos that's, mildly elevated, but not technically significantly elevated? So we'll talk a little bit about what our treatment goals are. I like to think about PBC in terms of the pillars of management. And this has been really nicely, demonstrated in all of our larger guidelines since 2018, really talking about how we should be addressing PBC treatment. So the goals of treatment are to, one, prevent the progression of liver disease, and two, to reduce symptom burden and improve quality of life. And when you're trying to achieve these goals, there's three things to really be focusing on. One is risk stratifying our patients and treating them appropriately. And we'll get a little bit more into how to best do that. The second is, how do you stage disease and what do you do for surveillance? And the third is managing symptoms actively. So remember, PBC symptoms and disease control are actually two different things. And that's why our treatment goals are really separated up here. So I think it's really helpful to think about these three pillars for every single patient that you see with PBC and try to help modify therapy in that way. So let's talk about the first pillar, which is risk stratification and treatment of PBC. And this is really where you look for the risk of disease progression in patients that have PBC. And it's really recommended that at baseline, you assess the risk of disease progression. And there's a few variables that you can look at to help understand this. One is age. We know age at diagnosis does play a role. The younger you are, the potentially higher risk there is of disease progression. Gender. So males tend to have higher risk of disease progression compared to females. Specific biochemical markers, and the main ones that we look at are albumin and bilirubin, and in the disease stage itself, looking at the degree of fibrosis. And that can really help categorize where a patient lands. So is this someone that is low risk, where there's just a mild elevation in alkaline phosphatase, they have a normal bilirubin, normal albumin, and no fibrosis? Is a more intermediate or high risk, where they have one of these potential risk factors, including a younger age, a higher alk phos over 1.5 times, an abnormal bilirubin, which is defined as greater than 0.6 times upper limit of normal, a low albumin, or do they have more advanced fibrosis? And then those that are decompensated obviously have a much higher risk and require much more increased vigilance and follow-up care. So, and the first thing to do is to all these patients, is initiate treatment with UDCA. So every patient with PBC, the first management step is initiating the adequate dose-based treatment. And this is with UDCA, 13 to 15 milligrams per kilogram per day. A few just key points here to make note of. One is that divided doses are as equally effective as a single daily dose. So sometimes historically, UDCA is normally divided up into QID 4 times a day dosing, and that's based on gallstone literature. And you don't need to do that for efficacy in PBC. So in order to improve compliance in our patients with PBC, we just recommend, as long as there's GI tolerance of it and no side effects, just take it once a day, and you can use the full dose once a day. There are sometimes insurance coverage issues with what is covered. Is it tablets? Is it capsules? They have equal efficacy rates. About 40% of patients that are on UDCA and on adequate weight-based therapy with compliance are inadequate responders, and that's when we look at an alkaline phosphatase cutoff of 1.67 times upper limit of normal. 5% are intolerant to therapy, usually due to GI side effects. And important to know that UDCA and even obeticholic acid, which we'll get into, does not improve pruritus or other PBC symptoms. So that's really the snapshot of ursodiol treatment for PBC. And then the next thing we do in all of our patients is assess biochemical response and figure out if they need second-line therapy. And that's sort of where our patient is right now. There are a lot more options for second-line therapy now. So 2024 saw the approval of 2 new drugs for PBC, right? So 2 new PPARs, seladelpar and elafibranor. And I think trying to figure out how to incorporate these into practice is important. But prior to that, all we had was obeticholic acid, and then the off-label use of fibrates, so fenofibrate, and for people that were going internationally to potentially get bezafibrate. So how do you define an adequate response? That was our second step up here, right? Is to assess if there's a biochemical response. So how do we define that? There are close to a dozen criteria that are available that help define biochemical response to treatment. And it's not really clear if one is better than the other. These have been, adjusted over time for the last 2 decades now. But these criteria exist. You can pick one. The ones that have been used more recently are the POISE criteria, so an alkaline phosphatase cutoff that's less than 1.67 times upper limit of normal, reduction in alkaline phosphatase by at least 15% from the start of treatment by 1 year, and then a normal bilirubin level. So that's what's been used in the trials most recently. But the biochemical response to treatment is, for the most part, if you look at all of these, really incorporates alkaline phosphatase and bilirubin levels. So that's how biochemical response can be defined. And then the time at which you assess whether there's a response varies based on which criteria you're using, anywhere from 6 months to 2 years. There's also prognostic risk score stratifications, which can help you understand whether or not someone is at low or high risk of progressing. And we sort of talked about the variables that go into that. I think that this is about to become very historic, and our guidelines will probably change in the next 2 years. So there's a fair amount of good data, good population level data, to suggest that we don't need to look at variable alkaline phosphatase threshold values anymore. Normal alkaline phosphatase and low bilirubin levels are actually what's best. So we don't need to look at cutoffs of 1.5, 1.67 times. We don't have to look at all of those different gradations of alkaline phosphatase abnormalities. It really is. It's really been defined in the last few years now that patients that can achieve a normal alkaline phosphatase value and a bilirubin level value that's less than 0.6 times upper limit of normal do the best. So the largest cohort of data comes from the Global PBC Study Group, which is a consortium of centers from Europe and North American centers. And in this particular paper, there was about 2,500 patients that were followed for over a decade in time. And they studied patients that achieved variable thresholds of bilirubin responses and alkaline phosphatase responsive. So this is looking at their time 0 cohort and 1 year cohort and their bilirubin levels. And you can see that the hazard ratio for liver transplantation or death, both at the time of diagnosis and 1 year after therapy, has an inflection point at about 0.6 times upper limit of normal. So that's where that number comes from. And then if you go here to the Kaplan-Meier curves on the right, this tells you how the curves sort of stratify based on alkaline phosphatase value. So the group of patients that did the best were those that had an alkaline phosphatase that was normal. So less than 1 times upper limit of normal. And there really wasn't much of a difference in those that had an alkaline phosphatase that was between 1.67 times and 3 times upper limit of normal, and those that were greater than 3 times upper limit of normal. So the survival difference can be seen between stratification of abnormal alk phos and a normal alk phos. So we really think the paradigm is going to be shifting soon to really encourage treatment to normal alkaline phosphatase values. We did a recent study and presented this at AASLD this year that looked at the target PBC cohort, which is a longitudinal cohort registry of PBC patients across many centers in the US, and observed patients over 5 years. And we recorded when their UDC start date was. They were not on any second line treatment at any point, and defined adequate response as pairs 2 criteria. And we looked to see whether or not they had a deep response indicating a normal alkaline phosphatase or a bilirubin less than 0.6 times upper limit normal, so really pushing to as normal values as possible, or an adequate response, which is what most of these trials have been using and what the FDA has been using to approve these therapies. So we stratified patients into these 2 groups, and the main outcomes that we looked at were complication-free survival, including decompensated cirrhosis, transplantation, and death. And what we found, this included 232 patients. We found that in 82% of patients that had a deep alkaline phosphatase response, so a normal alkaline phosphatase, 82% also had that low bilirubin level. About half of patients in both cohorts had advanced fibrosis, though. And when you look at how patients did, this is the hazard ratio to the complications. In patients that were able to achieve that deeper response, there was a significant decrease in the hazard ratio for developing those serious complications in both the deep alk phos and the deep bilirubin response groups. And the effect really seemed to be most pronounced in those that had advanced fibrosis. So we think that especially in patients that have advanced fibrosis, that they're likely to benefit from much more aggressive therapy. So really trying to treat to normal alk phos and normal bilirubin values. And this is probably where the paradigm is going to shift as we have more and more therapies that we can use for the treatment of PBC. And this, again, really demonstrates stratification based on liver stiffness measurements. So those that have advanced fibrosis or more, a greater degree of fibrosis, defined as a liver stiffness measurement greater than 10 kilopascals, compared to those that have a lower degree of fibrosis, and stratifying based on alkaline phosphatase values. And you can see that there's separation of the curves if you have normal alk phos, which are these 2 lines here, versus an abnormal alk phos. And the separations really do become quite dramatic in those that have fibrosis. The other question is when to assess the response to therapy. So historically, we've assessed the response to therapy after a year of treatment with UDCA. And perhaps we can consider earlier responses to therapy and look at starting second-line therapy prior to a year, especially in those in patients that are higher risk. So this was evaluated in the global PBC study group as well. And the study looked at over 1,000 patients that had PBC that were treated with first-line therapy. And what we found was that if we looked at an alkaline phosphatase threshold value of 1.9 times upper limit of normal at 6 months, you're able to really identify non-responders at a year. So you can identify the people that are not going to respond to therapy at 12 months, but you can identify them 6 months earlier with an 89% negative predictive value if you look at this threshold of alkaline phosphatase value. Do you have to do this for everyone? Probably not. If you follow this strategy, you will overtreat about 11% of patients, right? But you are going to adequately treat 89% of patients probably. And the goal is really that in those 6 months, can you prevent more bile duct damage? Can you prevent bile duct loss? Who are the patients that are highest risk of having that bile duct loss within those 6 months? And it's probably those patients that have advanced fibrosis. So we can assess response earlier. We don't necessarily have to wait for patients to demonstrate that normal alk phos or that reduction in alk phos at 12 months. But you can really assess response at 6 months, and especially consider doing this in patients that are at high risk or have advanced fibrosis. So this, I just want to really, in a single slide, capture how the treatment goals of PBC are changing. So remember, the goals are shifting to alk phos normalization, bilirubin less than 0.6 times upper limit of normal. This is all data from the global PBC study group, and assessing response early at 6 months, especially in those that have advanced fibrosis. So keep those two things in mind when you're following our patients with PBC now. The next thing that we sort of talked about was pillar 2, which is stage and survey patients that have PBC. And this really looks at disease staging and surveillance. So there's serum markers that we can use for fibrosis. So the FIB4, the APRI, the ELF, these are not actually quite well validated yet in PBC, but we can use them in conjunction with a transient elastography, so FibroScan or liver stiffness measurements. Imaging-based non-invasive tests seem to be much more reliable and have been validated in PBC. So liver stiffness measurements over 10 kilopascals on our FibroScans or with MR elastography over 4.3 have been associated with adverse liver outcomes, which is sort of intuitive, right? You have more fibrosis, you're more likely to do poorly over time. And you can use this for staging at baseline to help sort of categorize the risk of our patients. And in those that do have advanced fibrosis, just sort of remembering that HCC screening every 6 months is important, and then variceal screening for portal hypertension is important with advanced fibrosis. For those that don't have advanced fibrosis, I think reassessing the degree of fibrosis is important with elastography every 2 to 3 years as well to try to understand whether or not patients are progressing. Okay, and then lastly, we're going to spend a little bit more time at the end talking about how to manage some symptoms related to PBC. But we talk about disease control, disease management, but also thinking about quality of life and the symptoms of our patients with PBC and how to manage those. So pruritus we'll delve into a little bit deeper, but patients about 50% of patients will complain of cyclic symptoms, and fatigue. Neither UDCA or obeticholic acid improve these symptoms. And in fact, obeticholic acid can be associated with worsened pruritus in some patients, but can really be a challenging problem to manage. So it's really important to ask about dry eyes, dry mouth, untreated. This can lead to corneal ulcerations or oral ulcerations. And then management of dry eyes can be quite simple: artificial teals, pilocarpine, or cevimeline for refractory symptoms. And similarly for xerostomia or for dysphagia, you can do artificial saliva and pilocarpine or cevimeline for refractory symptoms. For fatigue, there's no recommended pharmacotherapy, but it is recommended that we rule out other potential causes for this fatigue. These symptoms do have a big toll on the quality of life of a lot of our patients. So it's hard to really delve deeply into understanding the severity of these symptoms. But I do think it is important for us to really assess for it as we sort of monitor our patients and try to, and we refer more therapy to assess their disease and control their disease, but really figuring out if we're improving the other quality of life and other symptoms they suffer from, we really have to focus on as well. So we'll go back to our case. Remember, she was started on alk phos. She was started on UDCA. Her alkaline phosphatase initially responded and then continued to rise after that. Bilirubin remained relatively normal, but perhaps upwards of 0.6 times upper limit of normal at times, and her albumin was normal. And what we did for her was, at this time, this was before I inherited her, and a long time ago, this was in 2007, it looks like. So her UDCA was increased slightly. So instead of taking 600 milligrams a day, her UDCA was increased to 900 milligrams a day. And that led to an initial improvement in the alkaline phosphatase values, but then it started to rise again by 2010. She had some repeat imaging done around this time, and her ultrasound was relatively normal spleen size, normal liver size. There wasn't any signs of portal hypertension. She had a FibroScan around this time as well, which did not show advanced fibrosis. So this is sort of how she was being followed up until 2017. You can see her alkaline phosphatase fluctuations. So I'll bring it back to the group now. So we're in 2017 in terms of her care. Any thoughts on what you would do for her at this point?
All right, I can just add in. So there was some responses too from the first time around. So Rena earlier said repeat biopsy, and I wonder if now, once we've discussed like second line treatment, if we would consider looking for like PBC, like autoimmune hepatitis overlap syndromes as well. And then, talking about some of our second line therapies too.
Yeah.
And assessing for adherence, of course. Yeah.
Yeah. And Omar just put in the chat. Sorry, I didn't click on the chat, even though I said put your stuff in the chat. So sorry about that. Omar also said potential obeticholic acid because we're in 2017. So I think, if her liver enzymes were rising as well, if her AST and her ALT were rising, and if you were really concerned about potential development of autoimmune hepatitis on top, then I think I would potentially repeat a biopsy after I'd probably start by reviewing some repeat serologies first, so checking the smooth muscle antibody, serum IgG levels, and see what those look like. But if our other transaminases are rising, then I would potentially consider evaluating for overlap syndrome or more autoimmune features to the PBC. I think that if it's predominantly the alk phos that's fluctuating in these, relatively controlled elevations and fluctuations that she has, it probably is the PBC that's just not being adequately controlled. So, what the docs that were taking care of her at this time ended up doing, because it was 2017, was starting obeticholic acid. So Omar, you're spot on. Obeticholic acid was approved in 2016. So it became available by then. She was started at 5 milligrams a day, and it was gradually increased to 10 milligrams a day. And her alkaline phosphatase, I think I have the graph later on. The alkaline phosphatase did reduce to 135, which is the lowest she had been in quite some time. So she did have a response to it. But unfortunately, she developed pruritus, and that led to discontinuation of the medication of obeticholic acid. And her alk phos started to rise after she discontinued the obeticholic acid. So just a reminder that obeticholic acid in the trials was associated with pruritus leading to drug discontinuation in about 5% of patients, but in real life and real world practice, it's probably a little bit higher than that. So in patients that do have mild pruritus at baseline, really making sure that you have adequate control of it before you initiate this therapy is key. Or thinking about other potential second-line therapies is important for those patients. And just a word on obeticholic acid, because I think we're going to hear a lot more about this year. So remember, obeticholic acid was first approved in 2016 based on biochemical endpoints. So this is improvement in alkaline phosphatase, not hard clinical endpoints, not showing improvement in survival or liver transplant-free survival. So the thought at the initial accelerated approval based on the POISE study by the FDA was that there'd be a definitive phase 4 clinical trial that looked at hard clinical outcomes. There was also a 5-year open label extension study that showed persistent response to obeticholic acid over the 5 years. During this period, while there was efforts to enroll in this phase 4 study, this was called the Cobalt study. While there were efforts to enroll in this study, obeticholic acid was commercially available. So, we were trying to enroll patients into a randomized study looking at the effect of obeticholic acid, potentially in higher risk patients, so we could capture those clinical outcomes in a disease that takes a very long time, while putting patients in a placebo arm despite a drug being potentially available. In the placebo arm, obviously, the patients, were usually patients that couldn't otherwise get the drug in any other way. So needless to say, it was impossible to enroll in this trial. The trial had to end, and we were never really able to show that there were hard clinical endpoints met with Cobalt itself. So that trial ended. So the guidance during this period also changed based on some events that were noted in patients that had decompensated or advanced cirrhosis, that there was some deaths that were noted with obeticholic acid in those that had Child's B and C cirrhosis. So there was a warning that was placed on the label, and the AASLD guidance was also updated to indicate that, or to really highlight that obeticholic acid is contraindicated in patients that have advanced fibrosis or portal hypertension. And then recently, at the end of 2024, there was the FDA met again and did not grant full approval in 2024, and they issued a complete response letter indicating that the benefit of obeticholic acid has not been demonstrated with the data that's available yet, and there's more to come on what happens after that. There's likely going to be, hopefully, some goals to work with all of us to figure out how to demonstrate that there is efficacy for the drug still. When you look at real world data and compare it to when you look at historic data prior to obeticholic acid and currently patients that are on obeticholic acid, there does appear to be an improvement in survival, but that hasn't been shown in randomized studies, obviously. So fortunately, though, 2024 saw the addition of other therapies, other second-line therapies for PBC. So we're not reliant on obeticholic acid only now, and we have other things to consider. So seladelpar and elafibranor were approved in 2024. These are PPAR agonists, and I'm going to spend maybe the next 10 minutes or so really discussing the data for these medications and give some, hopefully provide some nuances to help integrate these into practices. So PPAR, so peroxisome proliferator activated receptor agonists, PPARs, are a family of nuclear receptors. There's 3 isoforms, so alpha, gamma, and delta. And upon ligand binding up here, PPARs dimerize with retinoid X receptor, so RXR, and they regulate genes that are anti-cholestatic, anti-inflammatory, and anti-fibrotic effects. And the activation of each of these isomers has variable effects. So we'll start with PPAR delta up here. So the activation of PPAR delta, we see reduces bile acid synthesis, it inhibits proliferation of hepatic stellate cells, and it suppresses inflammatory cytokines. The activation of PPAR alpha also increases phospholipid secretion and bile acid detoxification. It reduces inflammation and it reduces profibrogenic genes. And then we have alpha PPAR gamma up here, which improves hepatic sensitivity to insulin and has been used for management of diabetes, and it increases fatty acid oxidation. So there's this class of drugs we've actually had a lot of experience with in the past because bezafibrate, which has been around for a very long time and has been approved for the treatment of PBC across the globe, but not in the US, is a pan PPAR. So it works on all 3 of these isoforms. And fenofibrate is a PPAR alpha, and we have a fair amount of experience with fenofibrate in terms of the management of PBC. The newer approved PPARs are seladelpar, which is a selective delta agonist, and then elafibranor, which is a PPAR alpha and a delta. So we'll focus on the the data behind these drugs now. So PPARs and PBC, when you think about the mechanism of action, so elafibranor is alpha delta, seladelpar is a selective delta. The dose for elafibranor is 80 milligrams once a day, for seladelpar 10 milligrams once a day, and both of these can be prescribed now. Some considerations, and we'll go into this in a little bit more detail, but some considerations are elafibranor is contraindicated in pregnancy or lactation. If there is an effect on hormonal contraception. So because elafibranor is an inducer of CYP P450-3A4, it reduces the efficacy of estrogens and progestins and can lead to ineffective birth control in those that are on hormonal contraception. So that needs to be taken into account when starting the medication. There's a potential bone fracture risk that's in the prescribing information. The initial trials showed a 6% risk of bone fractures compared to 0% in the placebo group. And there was a few cases of rhabdomyolysis or myositis, and in one patient that the rhabdo led to acute kidney injury, and that was associated with a patient that was also taking a statin. So there are recommendations on the label of monitoring CK levels and for risk of myositis in patients that are also on a statin. Remember what we mentioned earlier, that patients that are on or that have PBC do have a higher incidence of hyperlipidemia. And we think it's actually just related to the bile acid synthesis and the disease itself. So it doesn't necessarily confer a higher degree of coronary artery disease or higher risk of coronary artery disease. But if a patient is being treated with a statin, just something to keep in mind if you are starting elafibranor. The considerations for seladelpar, so bone fracture risk as well, which was 4% in the trials versus 0% in the placebo group. And I think that, in both of these trials, looking at these bone fracture risks, I think really just highlights the importance of us making sure that we're checking vitamin D levels in a patient that has cholestatic disease and ensuring that we're doing adequate bone density scans as well and treating appropriately. Monitoring for renal functions, there were associations with transient reductions in EGFRs in patients that were started on seladelpar. And the other important consideration with seladelpar is that it can improve pruritus. So in contrast to obeticholic acid, which potentially worsen pruritus, seladelpar can potentially improve pruritus. And that's something that can be taken into consideration when selecting your second-line therapy. The side effects for both of these drugs are actually, I think, quite similar. So GI-related side effects, abdominal pain, nausea, diarrhea, seladelpar headache, some weight gain associated with elafibranor as well. That's probably related to the PPAR alpha activity. Importantly, for both of these drugs, you can use it in patients that have child A cirrhosis, but you have to monitor for evidence of decompensation and monitor for synthetic function. And in patients that have child A cirrhosis, but that progress to B and C cirrhosis, so progress to having more decompensation or severe impairment, you should consider discontinuing the drug because it really hasn't been, we don't know the safety in decompensated disease quite yet. All right, elafibranor. So what led to the approval of elafibranor? So this was the ELATIVE study. This was a phase 3 randomized double-blind placebo-controlled trial that enrolled about 150 patients that had an inadequate response to UDCA, defined by alk phos threshold values and bilirubin values. Patients were randomized in a 2-to-1 fashion to receive either elafibranor or placebo for a year, and then could subsequently enroll into an open label extension for up to 5 years. The data showed that there was a biochemical response. This was defined by the POISE criteria, achieved in 51% of patients in the elafibranor group compared to 4% in the placebo group at a year. You had normalization of alkaline phosphatase achieved in 15% of patients at a year. And in patients that had moderate to severe pruritus, there was reductions in some values associated with pruritus in the 5D itch and PBC-40 scores, but not in the PBC worst itch NRS, which is what was used as the primary study point for assessment of improvement in pruritus. So there was, in terms of safety longer term, there is some data that we can review that was presented at AASLD. So there were about 138 patients that entered the open label extension, 93 that continued the elafibranor, and then there were 45 that crossed over after a year into the open label extension and to receive the elafibranor. And you can see that those that continued elafibranor had an ongoing sustained reduction in alkaline phosphatase. And in those that crossed over from the placebo arm to the elafibranor arm, they had a reduction in the alkaline phosphatase that was pretty similar to what was seen in patients that were first enrolled in the study. So the results from the ELATIVE study are what led to the approval of elafibranor, and more to come in terms of long-term safety, other quality of life, symptom improvement, and including fatigue, and what to do and safety in terms of cirrhosis as well. And then the RESPONSE study is what led to the approval of seladelpar. So this was the phase 3 randomized double-blind placebo-controlled trial that had similar entry criteria as the ELATIVE study for elafibranor. This randomized patients also in a 2-to-1 fashion to receive seladelpar 10 milligrams a day versus placebo for 52 weeks. This enrolled close to 200 patients, and then patients were similarly allowed to participate in the open label extension. The findings in this study, so similar, 62% achieved a biochemical response, so that reduction in the alkaline phosphatase value. The placebo response rate was higher in this group compared to the elafibranor, so placebo response was 20% in this group. And then normalization of alkaline phosphatase at a year was seen in 25% of patients. And then this is some of the pruritus data that was presented in the initial New England Journal paper. So the patients that had moderate to severe pruritus at baseline, there were significant reductions in the pruritus NRS score in the seladelpar group compared to the placebo group. So you can see that, even within 6 months, that there's a pretty good separation here in the placebo arm compared to those that were treated with seladelpar. And these are patients that had moderate to severe pruritus to begin with. Some patients that were enrolled in this trial did have cirrhosis. So there were 27 patients that had cirrhosis in this study. And the safety data in cirrhosis was presented at AASLD in this past liver meeting. So 18 of these patients received seladelpar and 9 received or were on the placebo group, and both had pretty similar baseline characteristics. This is pretty small study, but are pretty small capture of patients, but gives some initial insights. So what did we find up here? You see that there's relatively similar reductions in alkaline phosphatase in those with and without cirrhosis. So there wasn't much of a difference in efficacy in terms of reduction. And we also see that the bilirubin remained stable among those that had cirrhosis, and MELD score stayed stable as well. So we do see very similar cholestatic improvements compared to those without cirrhosis, and it appeared to be safe and well tolerated. All right, so let's go back to our patient. So this is now, we're in like 2019, 2022 now. She has alkaline phosphatase values that continue to fluctuate 150 to 220. Her bilirubin's 1. Her fiber scan went from 8 to 9, but relatively stable, still not advanced fibrosis. Albumin and platelets are normal, and mild pruritus. Remember, she was 60 years old. I think that this is actually close to 2022. What would you guys do now? So she didn't tolerate obeticholic acid. Remember, we had to we discontinued it, and she continues to have a little bit of pruritus, so it didn't fully resolve, or she has now recurrence of her mild pruritus. Hard to know. So let's pretend like we're in 2025, maybe. What would you do now? Let's forget about the past. What would you do in 2025?
Seladelpar.
Yeah, I think so too. So, um, it wasn't 2025 yet. So when I first met her, it was 2022. I should change the case a little bit, maybe. So I enrolled her in a clinical trial for seladelpar, and she was lucky enough to um, be in the treatment group. So we saw that her alkaline phosphatase really, really, quickly came back down to normal values. And I think within 3 months, it was down to 98, which is the lowest it had been in quite some time, and her pruritus resolved as well. So, it was a nice way to sort of treat two things at once, right? So we treated her mild pruritus. We also led to biochemical control and control of her liver disease as well. All right, I think we have maybe less than 10 minutes. So I want to shift gears very quickly, maybe to talk about cholestatic pruritus. And I will focus on the things that I think are important to really take away from this. We'll start with a question. So which medication is the only FDA approved medication for the treatment of general cholestatic pruritus? You can feel free to answer in the chat. So Omar says rifampin. Any other thoughts? Okay, we'll answer this in a minute then. So remember, cholestatic pruritus is itch that's associated with any cholestatic liver disease. It can be associated with a host of chronic liver conditions. So we know it's 100% prevalence in intrahepatic cholestasis of pregnancy. That's part of the definition of the disease itself. Patients that have cirrhosis, about 10% of them can just have pruritus as well. In PBC, we tend to see it in close to 80% of patients. It was previously thought to be closer to 50%, but likely underreported and underasked. And more recent data from Target PBC suggests that it's closer to 80%. It's rare to see in alcohol-related liver disease or metabolic-associated steatotic liver dysfunction. So we don't tend to see it so much in that. Remember the location, and when you're trying to differentiate why someone has pruritus and if they have cholestatic disease, remember, think that the location is usually in the limbs or the palms and the soles. It follows a circadian rhythm, so we're worse in the evening, worse at night. And you can see excoriations, you can see some other skin complications associated as well, like canification from where they're scratching too. The mechanism for cholestatic pruritus is quite complex. I think that I'll just highlight one or two things up here. One is that we know as liver disease progresses, so with liver failure, it's hypothesized, and we do see that pruritus tends to get better for the most part. And one of the things that we've seen, or one of the theories, is that the liver likely produced some sort of pruritogen or some sort of factor that plays a role in the pruritus itself. And one of a recent finding is the MAS-related G protein coupled receptor, so MRGPRX4. And this receptor is found in small sensory neurons in the skin. We've seen that bile acids and bilirubin deposit in the skin, and they activate this receptor and the sensory neurons. And in mice models, we can see an upregulation of this receptor leads to increased itching. And while serum levels of bile acids and bilirubin don't necessarily correlate with levels of itching, if you inject intradermally, if you inject bile acids or bilirubin, you can induce itch. So there's something in the sensory neuron itself that's likely activated by the bile acids of the bilirubin or some sort of cofactor that binds to and you can see that this receptor gets activated. Another important pathway is with lysophosphatidic acid, or LPA. We know that plasma autotaxin is one of the key enzymes that is the rate limiting step for the production of LPA. And this activates many different receptors on sensory neurons as well. And we see that activation of some of these receptors is associated with higher levels of interleukin 23, interleukin 17, and potentially 31, which are all known to potentially cause epidermal irritation and other dermatologic processes. And very interestingly, the only real serum correlation with serum levels and itch intensity is with autotaxin. So ATX is the only substance that we think is directly related to the intensity of pruritus. When you think about pruritus as well, I think about what is happening in a patient that has cholestasis. So we think that there's pruritogens in cholestasis that undergo this enterohepatic circulation. And the interventions to disrupt this circulation are shown here in blue. So at the level of the hepatocyte or the cholangiocyte up here, you can potentially interrupt this pathway. You can reduce bile acids from the circulation itself by reducing the reabsorption of these substances, or you can modulate the neuronal pathway, and that's done with some of these agents up here. So I like to think about the management of pruritus in these different buckets, and I hope that helps in terms of the treatment of it. So think about, how do you eliminate the pruritogen from the enterohepatic circulation? So that's bile acid binding resins, so cholestyramine, nasobiliary drainage, which we sometimes see on the pediatric side. We rarely do it on the adult side. Can you modify the metabolism of pruritogens in the liver or the intestine? And that's done with things like the fibrates or with rifampin. Can you modulate central itch or the pain pathway? And that's when we think about naltrexone. There's an imbalance in the opioid receptors in patients that have cholestatic itch. And can you modulate that differently? That can be done with naltrexone. It can also be done with sertraline. Or can you modify the itch perception locally on the skin? And that's done with topical agents. So I like to think about it in these buckets because honestly, we have a lot of tools, but they're so bad, right? We know that probably less than 10 to 15% of patients have their itch adequately treated, and most people learn to live with it. And for some people, it's quite severe and debilitating. So many patients cycle through drugs or on combinations of different drugs. There are newer therapies that are being studied for the management of cholestatic pruritus, and I think that we'll see a lot evolving in this field as well. Think about the management in this stepwise fashion. So starting with cholestyramine or other bile acid binding resins, these are very poorly tolerated, but the first things to potentially start with. Dosing can also be quite challenging because they have to be dosed apart from other medications, including ursodiol. Rifampicin, I think that in practice we start later, but we should think about it earlier because it can be quite effective. You have to be careful about monitoring hepatic function and bilirubin levels. Naltrexone can be sedating at times and can lead to withdrawal symptoms, but really working your way up. These are IBAT inhibitors. These IBAT inhibitors are approved for Alagills and PFIC, and then there's some experimental therapy as well. But to answer the question earlier, the only therapy that's actually FDA approved for general cholestatic pruritus is cholestyramine. For pruritus related to Alagills and PFIC, some of the IBAT inhibitors have been approved. I think we're running low on time, so I'm going to just spend a minute talking about the seladelpar itch data because I think that this is something to take into consideration when you're starting patients on the therapy. So this was data that was presented at ASLD. In patients in the response trial, itch was assessed using the NRS, the numeric rating scale, and moderate to severe itch was defined as greater than 4, severe as greater than 7, and resolution of itch as a value less than or equal to 1. There was also pruritus symptoms that were assessed using the PBC-40 domain. So in this trial, there were 72 patients that had moderate to severe pruritus. There were 49 that were in the seladelpar group and 23 that were in the placebo group. And you can see that seladelpar reduced the mean itch intensity from moderate to mild. And it did that by month 3. And by month 12, it was sort of maintained and more patients were able to get into the mild category. So I think that's quite impressive. I think the other thing to note that in those that had severe pruritus, there was improved sleep and there was improved fatigue. And we can see that that's probably intuitive. If you're itching all night, you're not going to sleep well and you're going to be tired the next day. And then I think one of the most interesting things here is that among patients that had no itch at baseline, so these are patients that enter the trial, no pruritus at all, at month 12, none of them had pruritus. So is it possible that seladelpar maybe potentiates the development of pruritus in patients that don't have itch? And that might be something that we'll see gets sort of flushed out more as data becomes available. So I think that these are important things to consider. I'm going to skip this slide on IBAT inhibitors. Just know that we are studying IBAT inhibitors for the improvement in cholestatic pruritus as well. And volixibat is currently being studied in PBC-related pruritus. So I'll conclude here. I think in summary, remember in our PBC patients, important to assess the risk of progression of liver disease in all patients using non-invasive testing. So FibroScan, use prognostic risk scores. You can pick one. I usually have the Globe PBC score in all my patients' notes. Determine response to first-line therapy at 6 months, especially at those that are at high risk. And remember that the response at 6 months, you look at an alkaline phosphatase of 1.9 times upper limit of normal. And the treatment goal for patients should be normal alk phos and a bilirubin less than 0.6 times upper limit of normal. The guidelines will likely evolve in the next few years to indicate this. Second line therapy options have expanded, and you really have to think about some of the nuances of particular patients to understand how to pick which therapy is best for them. And remember to ask and to treat for other symptoms associated with PBC, because a lot of our prior medicines that we had did not necessarily impact any of these symptoms. And it's really important for us to remember this is one of the treatment goals as well. So thanks everyone for your attention. Appreciate it.